Hi everyone, welcome and thank you for taking time out of your busy schedules to join us for this panel webinar, Diabetes FAQ Roundtable. This is the final session in Managing Diabetes, ARHP's 5-part course on the reproductive health implications of diabetes. My name is Priya and I'm the Membership and Education Associate at ARHP. I'll be moderating this webinar. Before we begin, I'm just going to make a few housekeeping announcements. If you called in using a phone and you get disconnected, please dial back into the number listed in your GoToWebinar registration email. If you have immediate questions regarding the webinar technology, please type them into the chat box on your screen. There will be a question and answer session at the end of the presentation. We look forward to answering your content-related questions at that time. An hour after the webinar, you'll receive an email from GoToWebinar with a link to the post-test survey. Just a reminder, it'll be 1 hour after the webinar. Your continuing education certificate will be generated upon completion of the survey. And in 6 weeks, you'll receive a follow-up assessment from us to gauge how you've integrated competencies into your practice. Finally, please note that this session is being recorded. The recording will soon be available to view on demand on the On-Demand Webinar section of ARHP's website. At this time, I'd like to introduce our panelists, Eleanor Bimla-Schwartz, Lori Gowron, and Emma Parker. We're thrilled that they could all join us today. Dr. Eleanor Bimla-Schwartz is Professor of Medicine at the University of California, Davis. Dr. Lori Gowron is Assistant Professor in Obstetrics and Gynecology at the University of Utah. Emma Parker, a women's health nurse practitioner, currently works in Northern California's North Bay Healthcare System as an OBGYN. For a full bio on each of the panelists, please visit the Managing Diabetes page on ARHP's website at www.arhp.org/modules/CME. At this time, I'm going to turn it over to our presenters who will begin the presentation.
So thank you. As we get started, we want to make clear that this session was made possible through an educational grant from Merck and Company, but they had no role in picking any of the topics or questions that we would answer or in specifying what we would be sharing with you, which we hope will be as evidence-based as we are able to make it based on our recent review of the literature. Our agenda for our time together will be this brief introduction. Then we're going to try to provide answers to some of the frequently asked questions that had come in after some of the prior webinar sessions, and open it up for live Q&A for questions that are burning in the minds of anybody on the line with us today. And I would encourage you to enter those at any point that you have questions using the technology that we have available today, and we will try to be paying attention to those in real time in an effort to make this as meaningful as possible to you, and then we'll wrap it up with a closing. So with that, I think we're ready to take a quick look at the topics that we're going to be covering. These include the ones that have been highlighted in previous sessions: how diabetes and reproductive health interact, general overview, as well as information about polycystic ovarian syndrome, the way diabetes and family planning interface, as well as questions related to diabetes and menopause. So the first question that came in focused on some of what I had been talking about was the question of whether a clinician should be screening patients for diabetes, patients with diabetes for depression and anxiety during each visit. And I guess I would start by saying it's hard to make any recommendations to do things at every visit because visits are always full, and especially for patients with diabetes who have a lot of different things that we need to take care of. But I think it's also a good reminder that depression and anxiety are very common, arguably even more common than diabetes among women of reproductive age. In some of the population representative studies, it looks like between 8 and 13%, maybe about 10% of people on average have depressive symptoms, and if we boil that down to major depression, that's probably between 2 and 3%. So it is something we want to be mindful of, and there are a number of good brief screening instruments, including the PHQ-9 or the PHQ-2, which involves just 2 questions that can be used whether or not our patients have diabetes. So I would say something to think about, definitely reason to think that patients who are challenged with managing chronic conditions may be a bit more susceptible to feelings of depression or anxiety, but not a reason to think that they are much more at risk than other patients we take care of. And it's not entirely clear to me that screening for depression and anxiety would need to bump out any of the other preventative health care that we need to provide our patients with diabetes, like screening eye exams, and as has been a focus of this conversation, reminder to address preconception care issues and contraceptive care issues for women who still are with the possibility of becoming pregnant. So I would turn it to Lori. Lori, do you have any additional thoughts you would want to add on that question?
Not on that question.
And Meshi, anything from you?
No, I think you were very thorough.
All right, so let's go on to our next question.
The next question is really combined between 2 questions that were asked about resources and suggestions for care for patients. This is a very general answer in the sense that many resource options are going to be regionally or institutionally specific. In my communities that I've worked in, I often identify clinic settings that have a track record for care for indigent or uninsured populations in order to assess the options that they provide in their clinical settings. Some federally qualified health centers or community health centers, homeless or uninsured clinics will have, even if it's just a day a month with a nutritionist coming in, or some of the other subspecialty care providers who can screen patients for some of the complications of diabetes. Additionally, many academic hospitals have patient assistance programs or resident or fellow clinics that care for these special populations as well. So really identifying resources in your community is an important part of this. But for those of you who are not living near any of these options, there are a number of online resources, especially through the American Diabetes Association, that could help fill the gap. If you have a patient in the office who may not have internet access, pulling up the ADA website and allowing patients to access internet-based counseling options can help fill that need. But also just talking about reproductive planning, contraception, optimizing health before pregnancy, these are issues that can be part of any preventive health visit and don't necessarily need additional outside resources for the basic conversation to happen. Now for adolescents, especially with type 2 or type 1 diabetes, there is a resource that you can access through the American Diabetes Association called Ready Girls. It's a free educational booklet that's really targeted for girls with type 1 diabetes and stresses the importance of reproductive planning while also discussing how diabetes affects sexuality, an important question for adolescents growing up with this chronic condition. When it comes to resources for nutrition for women with diabetes, for those who have the option, we always recommend that women meet with a nutritionist before pregnancy and then again during pregnancy. I talk to patients about looking at online resources, but you can't really adjust those recommendations to fit all individual patient needs. So an in-person nutritional consult has significant benefits. I always instruct the patient to start keeping a food diary ahead of time, keeping it for a week or so, and just comparing it to online recommendations. Again, the American Diabetes Association has great resources for nutrition before and during pregnancy, and also breaks down the resources into gestational diabetes, type 1 diabetes, and type 2 diabetes, so you can make it more specific for that patient population. So I'll ask if either Meshi or Bimla have any questions or anything they can add to this.
I would jump in. This is Bimla Schwartz, and say that I think it's often important for women who have type 2 diabetes and are heading into pregnancy with a body mass index over what we would think would be healthy for them to clarify that there is no need to gain further weight with pregnancy, and in fact the more weight loss that they can accomplish, the more likely they are to have healthy pregnancy outcomes. And that is a bit of a radical concept for some women, that pregnancy should be accompanied by weight loss, but depending on how obese a woman is when she begins pregnancy, sometimes it's actually more healthy to not gain any additional weight with pregnancy. The other bit of that I think is also just sort of a bread and butter issue that's really important for all women with diabetes thinking about pregnancy is the need for increased amounts of folic acid supplementation, and there's not entirely consensus on how much more than the over-the-counter prenatal vitamin 400 micrograms is best, but I think a folic acid as a water-soluble vitamin that it's not really possible to overdose on, and so I tend to encourage all women who might become pregnant, and especially those with diabetes who we know have increased risks of neural tube defects, to take a folic acid supplement if there's any chance that they could become pregnant and want to carry that pregnancy to term. Nashi, anything more from you?
No, I think you guys are doing a great job here.
All right, well, let's turn the question over to you.
Okay, well, welcome everyone again. We're just so glad you're here. The question that I have before me here is if LARCs are the best option for women desiring effective contraception. So why select combined oral contraceptives as a first choice for women with PCOS? And again, LARCs, the long-acting reversible contraceptives of the implant and IUD that you can see that beautiful visual right there. And yes, LARCs are very effective, over 99% effective, super convenient, so definitely is a great option for many people. The reason why we would think about recommending the combined oral contraceptives for women is because it can actually help them reduce their androgen levels in their bodies. So the estrogen portion of the combined oral contraceptive will increase the sex hormone binding globulin, a protein that floats around in the bloodstream, and will help grab some of the free testosterone. So in essence, you have less testosterone floating around the bloodstream that can attach to androgen receptors. And then the other portion of the pill, the progestin, will reduce LH secretion from the pituitary, and that directly results in androgen production. So the less LH you have secreted from the pituitary, the less androgen you'll have ultimately produced in the ovaries. So basically, that's what we're going for. You have a lot of women who have the hirsutism and the acne, and if you do the combined oral contraceptives as a first option and it works for them and they're interested in it, they can remember to take it every day, then you could kind of kill two birds with one stone. You can have the birth control aspect taken care of and also start addressing some of the androgen problems that they're experiencing. Lori, do you have anything to add?
Yeah, some of my patients who really need a highly effective form of contraception and acknowledge that they're like many of us and are not great pill takers, I'll have them on two separate methods at the same time. So considering placing an IUD or an implant and then adding the oral contraceptive is absolutely okay and provides highly effective contraception, but then gives them the ability to miss a pill but not be so concerned about risk of lower efficacy with the pill use. So that's an important option to keep in mind.
Yes, I think that's a great idea. I was sort of thinking along the same lines, but I think I might say that I think the implant in my mind is a very reasonable place to start. It does give you the systemic hormones, which the IUDs won't, and may provide some of those hormonal benefits of reducing circulating testosterone. You can always add a low-dose pill on top of the use of the implant, but the data that was submitted to the FDA back when the implant was approved would show that over half of women's acne gets better with the use of the implant. It's not labeled as a treatment for acne, but I think we need to be mindful that there are lots of options beyond those birth control pills which help with acne that do help women with their acne, and in fact really anything that suppresses ovulation I think of as improving acne. So that would include the pills but also the patch and the ring and the implant. So since the implant is the most convenient and most effective of those options in my mind, that's a very reasonable place to start for women with PCOS, but it's never my place to pick a method for a woman, and it's always really about what's going to best meet her needs. And I usually tell my patients to try them all, and once they've tried all of them, they'll know what the best one for them at this one time is, and there's no reason why we can't go back to a method that's previously been tried if after trying all the others they decide that even though they didn't love it, it was the best one for them. So let's go on to the next question. So the question here was, about yeast infections with diabetes. And there's two sides. The question was phrased as, are women with diabetes more likely to develop recurring yeast infections? And the answer to that is yes, especially if their diabetes is poorly controlled. And I think within that is the important message that there's a really big difference between having well-controlled and poorly controlled diabetes. And when we talk about diabetes as a health condition, what we're really talking about is poorly controlled diabetes. But if women work closely with their healthcare team and they get their diabetes well controlled, most of these complications of diabetes are much less common and much rarer. So if a woman has well-controlled diabetes, the answer to this should be no, because they won't have high levels of circulating sugar and there won't be anything for those yeast to sit around and chew on. But the flip of this question that I think is the really important take-home for people working in reproductive health care settings is that when faced with a woman who is having recurrent yeast infections, if she has not been screened for diabetes, we really need to have that thought go through our head, and we really need to make sure that we do screen her for diabetes, because treating yeast infections with purely antifungal medications, if the underlying issue is that her sugars are through the roof, is really not going to give her the long-term health benefits that getting those sugars under control would. So screening for diabetes, a quick blood test, a hemoglobin A1C. In some clinic settings, that can be a point-of-care test, and so you can have the answer even before she leaves clinic. Really important thing to remember to do. If you don't have a hemoglobin A1C, there are also cutoffs that can be looked at with random glucose levels, or the other poor man's approach is just to look at a urine and look for whether your dipstick has a bunch of sugar in it or not. Anything to add from any of my colleagues on this question?
This is
Meshi. So, oh.
Sorry, go ahead, Meshi.
Okay, so remember recurrent, what would be a normal amount of yeast infections per year? So if a person has less than 4, okay, you're not going to totally freak out. But recurrent is basically defined as 4 or more. And when someone has diabetes, then they are more likely to have a different strain of Candida, Candida glabrata versus the albicans, and that is not as responsive to the typical azoles, topical like the monostat or the diflucan, for example. And so that could be part of the issue, in addition to them having poorly controlled sugars, is they actually have a different strain of yeast that doesn't respond to the medicine that you're giving them. So if they are coming back to you repeatedly, then at some point you can think about doing a yeast culture and actually figure out what type of yeast they have growing there. And if it's not the albicans, then typically the glabrata works well with boric acid.
This is Lori, and in conjunction with considering yeast treatment, it's also really important to remember that women with diabetes may be more susceptible to certain sexually transmitted infections, and especially more severe sexually transmitted infections if they cannot manage them quickly. And so screening them for STIs and talking about STI prevention is an important part of this, and making sure that HIV testing is also done, as immunocompromised might be an underlying cause of recurrent yeast infections that might be different from the diabetes that we see as the more common cause of this.
And this is Bimla. Just before we leave that last question, I would also say one other issue that we should be mindful of when trying to help people with recurrent yeast infections is the way that blood in the vagina changes the vaginal pH and makes people more susceptible to yeast infections. So if we have a diabetic patient who is suffering with this and we're trying our best to get things under control, and we've tried most of the things that we think to do as first-line options, I think sometimes working on suppressing their menstrual flow using either, any of the multitude of options we have to suppress menstrual flow can sometimes increase our success in decreasing symptoms due to yeast infections. Sorry to slow us down. On to the next question.
So the next question, we put 2 questions together here because the response is similar. First is, are the cardiovascular risks with hormonal contraception and diabetes different between a woman with type 1 and one with type 2 diabetes? And the second is, does the fact that a woman maintains consistently good hemoglobin A1C levels change her cardiovascular disease risk with the use of CHCs? And so both of these really come down to, again, tight control of diabetes, and a woman who has great control of her sugars consistently is not likely to develop many of the chronic conditions that we're concerned about that go with long-term diabetes. And so the specific diagnosis or the fluctuation in A1C is really less important than the systemic effects of chronically poorly controlled diabetes. And the microvascular changes that compound over time really increase cardiovascular risks in general, and this includes with combination contraceptive methods, pills, patches, and rings that contain estrogen, but especially in the setting of pregnancy. And so remembering that if the alternative to not using contraception because of these concerns is an unplanned pregnancy, then that's not an ideal outcome for this patient or the outcomes. So we talked briefly in other webinars about the CDC's U.S. medical eligibility criteria for contraceptive use. And this is a great online resource through the CDC. There's also an app for this. And they rank the safety of hormonal contraceptives by vascular disease or duration of diabetes as greater than 20 years. So for women with these risk factors, the risk of estrogen-based methods outweigh the benefits. And really the first-line contraceptives should be highly effective methods such as the IUDs or implants, or the second-line method should be the progestin-only method such as pills or the injection. Do any of my colleagues have any comments on this?
I would just reiterate, does the fact that a woman maintains consistently good hemoglobin A1C change her cardiovascular disease risk? Absolutely. The longer she can keep her hemoglobin A1C below 7, the longer she will go without cardiovascular risk. And so the guidance around use of estrogen-containing contraceptives or combined hormonal contraceptives is with end organ disease or diabetes for at least 20 years, because generally there's few people who can have diabetes for 20 years and manage to have their sugars so well controlled that they end up with no end organ disease. But when we start seeing those end organ diseases, we worry that much more about use of estrogen. But I fully agree with what Lori was saying, that for all of our patients, we probably want to start talking about the IUD and implant as safer and more effective. That's not to say everyone has to prefer those, but they need to understand that those are going to be safer and more effective than the estrogen-containing options. In terms of the differences between women with type 1 and type 2 diabetes, since type 1 is more often onset during childhood, by the time we're seeing them in a reproductive health setting, it's that much more likely that those people will have end organ disease already. And so maybe we have to be a little bit more concerned about offering estrogen to people who have type 1 diabetes, although that's not a hard and fast rule. And there's clearly some people who have done meticulous jobs in keeping their sugars under control, using an insulin pump, for example, and really been quite successful for many, many years. The other side of things is that if women have type 2 diabetes, often they'll have a variety of other risk factors like hypertension and like hyperlipidemia that may also make us worry a little bit about their risk of clotting with use of estrogen. We know that obesity alone increases risk of both deep venous thrombosis as well as pulmonary embolism. So often a complicated conversation for women with diabetes, but one where we have a lot of different options, and there's lots of reasons to let women try those and make their own decisions amongst them. I guess the other thing I would add is that I also agree that our progestin-only options are preferred to the estrogen-containing options. In a study we did that has not yet been published, but you guys get breaking news here, looking specifically at women with diabetes and the different types of contraceptives available to them, and looking at whether there was differences in risk of clot with the different types of progestin-only methods. We were actually surprised to see that women using Depo-Provera and the progestin-only pills were considerably more likely to end up with risk of clot than women using an IUD or an implant. In fact, in this very large claims database we were looking at, there were no clots among women using implants who had diabetes. So I'm all the more convinced that those should really be our first-line options for women with diabetes, unless the woman has a really compelling reason why she'd like to use something else. And there have been prior studies, one from Holland that had previously reported that although progestin-only methods are generally safe, for risk of clot may be higher with Depo-Provera than the other progestin-only methods. The thought behind that being that the progestin dose in Depo-Provera is so very high. And so I think there's reason to just be a little bit more cautious with the Depo than I used to be, though again, I would prefer that to estrogen if given those as my choices. So I'll turn it over to our next question, and or Meshi, if you had anything to add on that one.
No, let's just go on to the next question here. What are the indications to start metformin in PCOS patients who are not seeking fertility? And I have to say the next slide is about metformin too, and we have another question coming up about metformin, so much so that I actually woke up the other day dreaming about metformin, which was a little bit concerning. So there's a lot of discussion about metformin in the literature and in the clinic setting. So the idea is a lot of PCOS patients have insulin resistance, and that contributes to elevated androgens. So why not prescribe this insulin sensitizing drug and help them decrease their insulin? So basically the easy answer is if they have diabetes, then type 2 diabetes, then metformin is a great option. If they have impaired glucose tolerance, then the idea would be you could prescribe metformin in hopes of preventing or delaying type 2 diabetes. And then beyond that, it's a little bit more complicated. So as far as for hirsutism, there isn't too much information. As far as weight loss, there's not too much definitive information as far as if metformin really would be more effective than lifestyle or other medications out there. So I'd say the short answer that I could find to this point is type 2 diabetes, or if they have impaired glucose tolerance. And then beyond that, the literature is a little bit gray in that area. Lori or Bimla, anything you want to add to that?
So I think of metformin as a reasonable adjunct to efforts at weight loss. And as long as it's well tolerated, I think of it as a very safe medication. I think of it as more useful in the treatment of insulin resistance than in perhaps treatment of fertility. I think, though, there were some initial studies showing that metformin might be useful in promoting fertility in patients with PCOS. The data on whether it actually increased live births was much less compelling, and clearly people who are seeking pregnancy are really not just seeking pregnancy, they're seeking a healthy live birth. So I guess I would say I don't think there's a clear line in the sand where we need to start metformin, but if patients are looking for a pharmaceutical assist, and often people are interested in that because it's so very difficult to make the lifestyle changes that we talk about as if they would be easy to result in weight loss, but living in the sort of toxic food environment that we live in, where it's difficult for people to generally get as much physical activity as they might need to burn off all the calories that are easy to come by. Sometimes it's helpful for people to have medications that help them not convert the stuff they have stored in their liver into increased glucose stores. Lori, anything more from you?
No, I don't have anything to add on that one.
Okay, so then what are the side effects of metformin for treating PCOS patients? And basically the most common side effects that people experience are the diarrhea, the nausea, vomiting, and it's the lactic acidosis that you sometimes hear about is incredibly rare. That's mainly with high-risk patients with renal, liver problems, or congestive heart failure. So basically the GI side effects is the main aspect that we hear patients complaining about, and this is why you want to increase their metformin dose slowly when you start them on it. So 500 milligrams once a day, and then over the next few weeks increase to maybe 2 to 3 times a day. So most people will be on about 1,500 to 2,000 milligrams daily. And as far as effects on men's yeast and ovulation, so we'll talk about this in a moment in a few slides. But basically, some people can start ovulating on metformin. Actually, one of the studies did show that it was more related to if you lose weight on metformin than if it's just you're on metformin in itself. And it's not necessarily, if you don't lose weight on metformin and you're just taking metformin by itself, then you're not really going to see a lot of changes in a person's ovulation and menstrual cycle. So they may see some changes in their cycles if they end up losing weight on metformin, I guess I would say. And if they're not having regular cycles, remember you still need to think about endometrial protection and making sure they get regular withdrawal bleeds, or even better, are on some kind of birth control to give them that as well. Lori, Bimla, anything to add?
No, I think you did a really thorough job on that one.
Yeah, I agree.
So, and just before we go on to this next question, I did see there was one that came in from the live field about use of clomiphene for patients with PCOS or diabetes who are on metformin and seeking fertility. And as best I know, that is not a contraindication to use of clomiphene, and that is something that sometimes our fertility specialists would think about moving with. Lori, any thoughts from you on clomiphene for people with PCOS or diabetes?
Many of our infertility specialists are now moving away from Clomid with PCOS patients and transitioning more to letrozole, but I think that that's more provider dependent at this point of whether they'll trial Clomid first versus going straight to letrozole. But there is more and more evidence showing benefits of letrozole in these patients who are not responsive to Clomid and have these diagnoses.
Makes sense. So our next question is about the potential teratogenicity, or the likelihood that birth defects might result from use of medications like oral diabetic medications, and especially the newer classes like incretins. And so the first part of this conversation is that the most teratogenic condition that we have when talking to women about diabetes is poorly controlled sugars. And women whose sugars are giving them an A1C up in the 8 or 9 range are really going to be facing risks of birth defects that are about 2 to 3 times the risk of the healthy population. And that's way worse than what we have reported for almost any medication out there except for isotretinoin or Accutane. So within that context, we have to just be really mindful that untreated disease can be really a terrible thing for women during pregnancy. That being said, we have very little data about use of the newer medications like the incretins during pregnancy, and people tend to remain pretty cautious about use of any of these during pregnancy, with insulin being the usual go-to for people during pregnancy, although there have been some recent studies using oral agents, but again, the older oral agents, metformin and glipizide during pregnancy, that seem to have reasonable pregnancy outcomes associated with them. So I guess my statement would be framed always by where the patient was in terms of thinking about her pregnancy and thinking about her risks and whether she wanted to get pregnant or not, and how terrible it would be if she did end up pregnant when she didn't want it be to have an abortion. But the absolute risk with any of the oral diabetic medications seems to be within the range of commonly used medications. There hasn't been any signal in animal studies or other early data from the very rare women who have used these medications during pregnancy without meaning to, that seems to make us think that these are much worse than all other medicines, but it always takes some time to get good data about these use because they're relatively rarely used. Lori, anything you want to add in terms of your experience as an OB?
Yeah, I think most of the time in obstetrics, when we can plan for pregnancy, we're going to err on the side of caution and use the medication management regimens that we have great data on. And so for patients who are using these alternative therapies, again, it comes down to preconception counseling and avoidance of an unintended pregnancy, as you pointed out, if they are going to be on these options. And if not, and if they're not willing or able to use an effective form of contraception, then this might not be the best option for them.
And then the other thing to remember is that our diabetic patients often come on not just one medication, but on multiple medicines for their general vascular condition, and that includes statins to try to lower the risk of heart disease, and statins are labeled as not to be used during pregnancy, and then ACE inhibitors for their blood pressure and renal protection, and those again are not to be used during pregnancy. So it would be quite common for a woman who was just on standard treatment for her diabetes who ended up with an undesired pregnancy to all of a sudden be realizing that she's taking medicines, at least 2 to 3 of which carry a label as not to be used during pregnancy. That being said, if she decided she wanted to carry that pregnancy to term, I think there's a reasonable chance that the absolute risk of an adverse outcome would be still relatively low, but concern has been raised with use of each of those medicines alone, and we don't have a lot of experience with women who've used that whole combination of medication in early pregnancy. So let's go on to our next question.
I think that was a great segue into this question, which is, can you tell me more about medication management of diabetes during pregnancy? And again, this goes back to trying to plan for pregnancy to make sure that we've optimized medications as well as diabetes control, ideally 3 to 6 months at least before a woman plans to get pregnant, if not longer, so that you could make some of the lifestyle changes and maybe affect some weight loss before pregnancy happens. Now, this is a more general question in that there's not a specific type of diabetes or a patient that's referenced in it, but our overall goals of diabetes management during pregnancy is really focused on optimizing blood glucose levels without causing maternal hypoglycemia. And so depending on the diagnosis, this could include, well, always includes diet and exercise, talking about weight gain goals, as Bimla pointed out earlier. And then it may include oral agents and or insulin. And some of this depends on the patient's ability to adhere to these methods, what they were using before pregnancy and their needs during pregnancy. But again, if a patient is not able to access insulin, even if she doesn't need to be, or if she needs to be on it, if she's not going to be able to access it or be adherent to it, it's always better to get whatever control you can get through oral agents and lifestyle changes. This is a lot of partnership with the patient, frequent visits throughout her pregnancy and ideally beforehand. And it's also important to remember again that even though type 1 diabetics may seem more brittle to manage during pregnancy, that the comorbidities that are associated with type 2 as well as gestational diabetes, such as obesity or hypertension, as we pointed out before, could actually put these women at greater risk for complications during pregnancy. So really engage a partnership with the patient, engage your resources locally, whether it's endocrinology or high-risk OB, and get the support that you need in the management decisions that are specific to that patient and reasonable with her ability to manage her disease. Misha, do you have any comments?
And this is Bimla. I would just jump in for 1 second before letting Meshi talk and say I think the image on this slide is very pretty but a little bit misleading because really so much of the time we're not going to be using pills to manage diabetes during pregnancy, and really often it's a conversation about a transition to insulin. Sorry, Meshi, back to you.
No, actually, Bimla, I didn't have anything else to add on that one.
All right, well then let's go on to the next slide.
Okay, so can PCOS be reversed or cured, or control their symptoms? So unfortunately, we don't have a cure at this point, but people may be symptom-free for a while if they are able to continue some of those interventions that have worked for them. Lori or Bimla?
This is Lori. I for the patients who are really averse to management of PCOS, I really try to get them into the lifestyle modification support groups. For example, I work in the VA Women's Clinic, and we have a great support group for women for obesity and nutrition management. So finding those resources locally can help women to decrease their BMI and potentially reverse some of the adverse effects from PCOS.
That's a great reminder. Actually, so if you guys are looking for additional resources online, there are discussion groups, there are various online chats, some of them which are medically supervised by either nutritionist or nurse or physician, and those are listed under the PCOS provider resources for Module 2 as well.
Great. So the next question is about the specific effects of different contraceptive methods for perimenopausal women with diabetes. And I want to partner with one of the other questions that I saw come in over the live chat, which was a question about do we have to worry about any of the progestin-only contraceptives increasing women's appetite, and is that even more of a concern for women with diabetes? And so weight gain is often a concern of women when I talk with them about both contraceptives and other healthcare issues, and luckily this is an area that has been pretty rigorously studied. There does seem to be data that some women, not all women, but some women gain weight. We have data that they gain weight when using Depo-Provera, and those women tend to gain weight early if they're going to gain weight. So I always say, you know, if you've gained a lot of weight after your first Depo shot, it should probably be your last Depo shot, because stopping the Depo doesn't seem to make that weight melt off of people. That being said, the implants do not seem to have that same tendency to increase weight gain, and Mirena doesn't seem to either, and I should be expanding that from Mirena to Liletta, since we now have that generic version of Mirena available as well, and it's so wonderful to have that lower cost option available. So I would say I'm a little bit cautious about use of Depo in women who are already obese, but if people think that it's the best option for them and they've used it in the past and don't feel that it's made them gain weight, then I would say, you know, if you've tried it in the past and you haven't been someone who gained weight with it, you shouldn't be somebody who's going to start gaining more weight with it now, and that all of those options would be reasonable. In terms of thinking specifically about women in the perimenopausal period, I think a little bit more carefully about their risk of vascular disease. So I'm a little bit more cautious about offering estrogen unless there's some reason why their needs can't be met with another option. And then the other thing that often ends up becoming much more of an issue for perimenopausal women is trying to control heavy periods. And so I do a fair amount of talking to women about whether or not they like having their period and reassuring them that it's actually very safe not to have a period as long as you're using hormones to keep the lining of your uterus from not building up. So because fibroids become more common as women head into menopause, we see a lot of women with heavier periods, and many of them find things like placing a levonorgestrel containing IUD quite a relief. And so that's often one of my favorite options for perimenopausal women. But otherwise, not too much that I think about very differently. Again, with women with diabetes, we have to worry as time goes on that there's that much more risk that they will have developed end-organ disease. And if they have end-organ disease, then we need to be that much more cautious about estrogen. But otherwise, in many ways, much the same conversation that we can refer back to the guidance given by the CDC's medical eligibility criteria, which would say that really women can choose whatever method they think is going to be best for them unless they've had diabetes for over 20 years or they have some known end-organ disease like vision loss or neuropathy, loss of sensation in their feet, or other vascular disease. Anybody have anything that they want to add to that one?
Lori, just to reiterate the fact that in the question that was submitted about the progesterone-only contraceptions, just a reminder that not all progestogens are equal in the setting, and so and not all patients are going to respond to the progestin that's in a specific method the same. And so, as Bimla pointed out, it's a small proportion of women who do gain weight, but they often are these patients who gain a lot of weight very early. But Depo-Provera is a large dose of a true progesterone, so it's very different from the other androgen derivatives, which are the progestins in the other methods, such as Mirena implants, progestin-only pills, or the progestin that's in the combination pill. And so it's going to act differently. So often patients will say, well, I don't want any of those other methods like the hormonal IUD because I gained weight on this other progestin-only method. So reminding your patients that it's a very different drug than the androgen derivatives that are in the other progestins.
The last thing I wanted to mention that I would add is the Mirena especially is, aside from helping people not have crazy periods around perimenopause, if they do end up choosing to go on hormone replacement therapy for just unbearable hot flashes, then it could be, the IUD could be an option for them to provide endometrial protection that's not adding on an extra oral progestin, which does have some breast cancer risk over time. So it can be a convenient way for them to, protect the uterus and also be able to go on the estrogen for the hot flashes.
Great point. So let's go on to our next question.
The next question is, can you review best evidence for switching different OCP formulations to manage side effects, and is there really good science behind this? So switching oral contraceptive formulations can often be done to manage side effects, but one of the hard things with this is getting patients on board to give it a trial of time with each method, because often within a couple of months, if they don't like the pill, they don't like the pill, regardless of whether you're switching. But if it's a patient who's really committed to taking the pill and wanting that method, it really depends upon the side effect that you're trying to manage, whether it's an estrogenic or a progestin-related side effect. So just remember that most oral contraceptive pills on the U.S. market contain the same estrogen, so ethinyl estradiol, but it comes in varying doses. And so there are a number of progestins that are used in different pill formulations that may have different androgenic side effects. So for a new pill user, I often choose a monophasic pill with about 30 micrograms of ethinyl estradiol. And many of my colleagues will choose a pill that has norgestimate or levonorgestrel in it, just because we have some longer longitudinal data on these methods for safety. But the monophasic pill will give you some flexibility for continuous dosing too if the patient desires. And then I talk to the patient and give some anticipatory guidance on irregular bleeding and also likely resolution of any estrogen-based side effects such as breast tenderness or nausea within about 3 months. So it's really that, kind of like with the Mirena, I contract them to use for a few months and see how things are going and have them keep a side effect and bleeding diary along with it, because they might realize 2 months later that they are still having it, but it's fewer days that they're having that symptom, and so they're willing to stick it out for longer. If they are experiencing progestin side effects, such as acne, these can sometimes take a couple of months to appear, and so again, giving it that trial of time to see if it's going to be a bothersome issue for them. And then at about 3 months, if they're still having issues, if it's an estrogenic side effect, you can switch to a lower estrogen dose. Whereas if it's a progestin side effect, looking at one of the other progestin categories that might be less androgenic can help to manage those side effects. But better yet, as we talked about before, transitioning to an alternative contraceptive method such as an IUD or an implant might be the better option, just because pills have the highest failure rate of the effective or highly effective methods because of user error. And of new pill users, often only about 50% are using them about 6 months in, so they're coming off of their method and not having the effective form of contraception they planned for. Does anybody have any other comments on that?
This is Bibla. I would just add, I really like the fact that we now have packages that come with extended cycles, and that the Affordable Care Act has made those affordable to many more women than used to have access, and I think there's a lot of reason to think if we're going to be using a pill, we should really be using active pills and not placebo pills, both for safety and effectiveness. So my usual go-to is now Introval, which is the generic covered by California's Medi-Cal, but I would just encourage you to find what the extended cycle product in your community that is cost-effectively available to your patients if you're going to be using a pill, and think that that's probably a good starting place. I don't think of there being super good science between pill-to-pill comparisons, but I am a pretty big believer in each woman being the expert on her own experience, and I think the good news is that there's 100 different formulations on the market, and if somebody wanted to try them all, I would be happy to try to facilitate that. But I fully agree with you, Lori, that often it makes a little more sense to try some of the other modalities instead of trying all 100 pills before you step off and try an IUD, because we know that typically 80% of people are happy with their IUD or implant at 1 year compared to only 50% of the pill patch or ring users. Meshi, anything more from you, or you want to go on to the next slide?
The one last thing is you will have people who will complain of low libido or feeling depressed on the pill. Many times that's not the case, but I just tell them basically, if you are experiencing this, let me know. Don't suffer by yourself over there, and we can try a different method, a different pill. There really, unfortunately, is not good science behind figuring out, okay, if a patient has low libido on this pill or is depressed on this pill, then what type of formulation should you switch them to? So that is, just like you said, Bill, is kind of hit or miss, and you help them try different ones if they're up for it, or switch them to some different method. Okay, so how can I help patients overcome infertility caused by PCOS? So this is such a stressful thing for patients, especially when they are ready to have a child and they keep getting that negative pregnancy test or get a period when they weren't expecting it. So the good news is that about 60% of PCOS patients will be able to conceive spontaneously within a year, but the flip side of that is about 40% are not able to, and there's a big discrepancy because PCOS is heterogeneous. Not everyone presents the same. Some people are at normal weight, some people are not, and their androgen levels are different, their lifestyles are different. So, but PCOS is the most common cause of anovulatory infertility. One study did find that of those 40% of infertile PCOS patients, 90% were overweight. So that is going to be one of the main things as a primary care provider that you're going to help them focus on, is losing a little bit of weight. And it's not going to take a lot for them to start ovulating regularly. Just a 3 to 5% weight loss can help them have spontaneous ovulation. So that's the first line, actually, is going to help them with their lifestyle. Now, if they are ovulating and unable to get pregnant or at a normal weight, then there's not any evidence that further weight loss for a healthy weight PCOS patient is going to help them conceive. And so I think the best thing at that point is to help make that referral to the infertility or OBGYN department that you work with. Now, as far as timing sex, sometimes people think they're infertile because they have been trying for a month or two and they should be pregnant by now. That's what they think, and so they come to you all worried, and really just reminding them that it takes time. It can take up to a year to get pregnant, and that's within the normal realm. And for them to figure out when they are ovulating. And again, not everyone will be ovulating because of the PCOS, but sperm can live for 5 days in the genital tract, and so ideally they would, and the egg, remember, can only live for 24. So there's a small window within every month where they can get pregnant, and having sex every day around that time period is going to increase their chances of getting pregnant. Having sex once a week during that time period is not not enough necessarily, and having sex multiple times a day is going to stress them out potentially because they're wanting to conceive, and also it's going to decrease the sperm in the ejaculate as well. You can help them get an ovulation predictor kit, and those can be a little bit expensive, but that's also one way that they can see when they should have sex. And the one thing to know is that if they are noticing that their ovulation predictor kit, for example, Clear Blue is what we often recommend. So if they are if the ovulation predictor kit is constantly showing that they've ovulated or that they're fertile, then sometimes that can happen just because of the elevated LH that is associated with PCOS. And in that case, the ovulation predictor kit is not going to be very helpful to them. So the number one thing is make sure that they are starting to get some exercise in and some nutrition reduction as far as calories are concerned. Usually about a 500 calorie deficit daily can ultimately result in a 7 to 10% weight reduction over 6 to 12 months. So you don't want some really quick diet for them to drop the weight, because ultimately you want them to develop that healthy lifestyle that they can maintain during pregnancy and after to reduce some of those long-term risks. Lori, Bimla, anything you want to add to that?
No, I think you did a beautiful job with that one. I guess maybe the only question would be the second half of what's on this slide, the head-to-head metformin versus weight loss versus both. And I would say it seems like, as you had said before, it's generally the weight loss. But there's probably no harm to putting both in action if this is what people are looking for as their outcome.
I agree, and also, I just think that fertility and pregnancy planning is such a great motivator for women for a lot of reasons, and encouraging this time to really focus on a long-term sustainable plan is important, because this is not going to end after their pregnancy is complete.
To piggyback on that just for one moment, and then we can move on, there is a genetic component to PCOS, so the other part is to remind them that if they're able to have a healthier body during pregnancy, then there's some gene expression that can happen that would potentially help their children not develop PCOS down the line. So it affects not just this pregnancy and their own health, but it can also affect the health of their offspring.
Hi all, in the interest of time, we're going to move on to the next slide and wrap up very shortly.
So it looks like this one's for you, Meshi. Again, what's the first-line ovulation induction method used for patients with PCOS?
Okay, so right now, ACOG and some of the other consensus statements still are listing Clomid as the first-line ovulation induction method. This basically is going to increase FSH levels and then lead to ovulation. Now it's about 75 to 80% of the patients will ovulate on Clomid, and there's about a 22% conception rate per cycle. Clomid is right now the common choice because it's tolerated, low cost, it's an oral medication, there's not a lot of side effects. But like Lori mentioned, there is more attention being drawn to letrozole, the aromatase inhibitor, and I don't know if, Lori, you want to mention a couple things about that.
I don't know the percent success rate
Okay.
on offhand, but again, I think it's still a little bit individualized based on providers, and many are still giving that first line, 3-cycle or 2-cycle on Clomid and seeing what the response is. And then if they're not seeing appropriate follicular development on ultrasounds, then they're transitioning sooner than later to letrozole.
Yeah, so cumulative birth rates on Clomid for 6 cycles, they wouldn't really go beyond that because they don't find it likely that they're going to conceive if they haven't done at that point. By then, it's about 50 to 60%, and it's going to depend on the patient's BMI, androgen levels, age. And just a quick reminder, since we are on a metformin kick here, the metformin doesn't seem to really add much for ovulation and, well, ultimately in live birth rates compared to Clomid. So they may use it sometimes in Clomid-resistant patients, but in general, Clomid is the first line at this point. We'll see what happens down the line.
Great. Thanks so much to Meshi and Bimla and Lori for this wonderful presentation. Since we're running out of time, we're actually going to skip the live Q&A session, but we have been noting your questions. Please feel free to continue to submit questions. We will assemble these questions and share these with our expert presenters and follow up with you with more detailed information and answers to the questions that you've asked. In just a moment, I'll tell you how to collect your continuing education certificate. But first, we'd like to direct you to ARHP's Managing Diabetes series. The previous 4 sessions were already held, and the on-demand webinars are available on our website at www.arhp.org. All of these resources, including today's webinar, are brought to you free of charge. Well, we hope that you will help us keep these resources free and open access by becoming a member of ARHP today. Additional resources like our clinical minutes and other slide decks are also available, so we hope that you'll check those out. And now to the post-test survey. You'll receive an email from GoToWebinar 1 hour after this session ends containing a link to the post-test survey. After completing the survey, you'll be able to print your continuing education certificate. Please be sure to print the certificate before the window closes. Sometimes this can be an issue. If you have any questions or you aren't able to print your certificate, please don't hesitate to email us at education@arhp.org. Thank you again for joining us today. We really appreciate all the questions that you've asked and look forward to hopefully seeing you on future webinars. Thanks again.